Welcome everyone to today's LHS seminar. As you know, this is a monthly virtual seminar. It's open to everyone at Women's. You can find previous sessions from going back to September 2023 on our website. Okay, and to start with, we will do a land acknowledgement. So we acknowledge that the land that we work and meet on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabeg, the Chippewa, and the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. So you can see that including today, we have about 5 sessions remaining in the season. We're very much looking forward to showcasing talks around LHS and an introduction to that, but also on focusing on advancing health equity, food insecurity, and also highlight some of the work being done here at our hospital. Great. So, right. And just a heads up, we will share this link at the end of the talk as well. We'll share it in the chat. This is just so you have the link to an evaluation for today's talk. We just want to, hear about your thoughts and any suggestions that you may have. Great. So without further ado, I'm happy to introduce our speaker for today, who will be speaking on realizing the vision of a learning health system. And happy to introduce Dr. Sunil Kripalani, who is a professor of medicine at Vanderbilt University Medical Center in Tennessee. This is Dr. Kripalani directs the Center for Health Services Research and also serves as vice president for Health System Sciences. He previously founded and served as chief of the section of hospital medicine at Vanderbilt. He leads several research and training programs in implementation science and learning health systems dedicated to improving healthcare delivery and health outcomes by optimizing quality, value, equity, and patient-centered care. He has expertise in improving transitions of care for hospital patients with a focus on health literacy, social determinants of health, care coordination, and medication safety. Welcome, Dr. Kripalani. We're very excited to hear your talk. I know there's a lot of interest in the work that you're doing, so I will let you start sharing your screen. And if I can remind folks, please feel free to use the chat if you have questions, but we will have a designated time towards the end for Q&A as well.
Great. Thank you so much, Somi, and I really appreciate the invitation to join you all from Nashville. As you might have gathered, my career's been a bit of a journey, and one of the things I enjoy most now is working with our clinical and academic enterprise to advance our work as a learning health system at Vanderbilt, and I'm hoping to share some of that with you today. So our objectives for our time together include, first, just beginning at the beginning. What is the promise and major functions of a learning health system? Next, I'd like to share some examples of methodologic approaches used to accomplish learning health system research using a broad variety of health services research techniques. And I'll describe our own journey as an institution as we continue to evolve as a learning health system. So when we're in clinical practice, questions come up all the time. If you're working in a hospital setting like mine, you might wonder, what are the best ventilator settings we should use? How much blood should I transfuse? Which antibiotic regimen should I give a patient empirically? And what are the early warning signs of decompensation? A lot of times these questions come up and we might chat about them for a minute and make a decision, but there isn't always a clear answer. And we miss a lot of the opportunities to advance our knowledge of how to care for patients. We might say, well, isn't that what research is supposed to do? But the problem is that the traditional approach to research is slow and follows a leaky pipeline. Many of you may have seen this figure before, which is over 10 years old now, and illustrates that our traditional models of science moving to evidence, moving to patient care, and hopefully impacting patient outcomes and experience takes a long time. We lose a lot along the way. Insights may come up that we don't manage well, and we rarely incorporate the patient perspective in a lot of this work. And so we lose a tremendous amount in this approach. About 30% of the research that we begin actually makes it all the way through this pipeline. And about 50% of the care we provide in clinical practice isn't based on the best scientific evidence, unfortunately. And this problem is only widening in terms of a gap between the evidence that's available and what we do in clinical practice. We can call it the implementation gap, and over time, as more and more medical research is conducted, we just aren't keeping pace with it in terms of how much we do in clinical day-to-day care. So around these challenges, the context of a learning health system was conceived as an approach in which science and informatics and institutional culture could all be brought together around a concept of developing the best evidence, using it in clinical practice, and applying it to patient care, generating questions along the way and turning those back into other scientific questions that we can answer. All this needs to be aligned and part of an institution's culture as it was envisioned by the National Academy of Medicine. The Agency for Healthcare Research and Quality conceives things a little bit differently, a little bit more succinctly too. And ARC describes a learning health system as one in which internal data and experience are systematically integrated with external evidence, and that knowledge is put into practice. So both of these models involve some sort of cyclic flow between questions and evidence and answers. But the ARC definition incorporates a little bit more heavily the notion that the evidence can come from the outside. We don't necessarily have to generate it in our practice. You might see other diagrams which are commonly used to describe a learning health system, and they share a lot of the same elements. I think the one on the right is probably more widely used in Canada. The data to knowledge, knowledge to practice, practice to data flow is all getting at the same idea of developing questions, collecting data, analyzing it, interpreting it, using it, and then taking action in clinical practice. So let's look at this another way. So if we're going to realize this vision, what are some of the characteristics that we would need to have in a health system? One is that we should be able to learn if we're a learning health system. Another is that we need to be able to do it rapidly. The traditional scientific pipeline, they say 17 years to move something from idea to practice. It's just obviously too long. We need to do things continuously in an improvement cycle, have an infrastructure that supports this. And as I mentioned before, it all needs to be part of the institutional culture. What a learning health system is not is collecting data, analyzing it, interpreting it, and publishing it, and saying mission accomplished. But unfortunately, that's what a lot of our traditional research follows. And that is not sufficient to advance our world as a learning health system. So if we realize that we need to do things a little bit differently in order to advance our health systems along this pathway, what are some basic capabilities that we might need to have? We need to be able to get data and analyze it. We need to be able to design and implement interventions. We need to iteratively improve. This might be new work in which we're using real-world clinical data for research purposes, so we need to have some privacy and regulatory safeguards around it. And we need to do this in a way that engages all the people who are stakeholders in this process, from patients to health system leaders, and also do it in a way that's scalable and sustainable. Doing this in just a small pocket of a health system is a good place to start, but that doesn't fully realize the vision of a learning health system. If you're setting up a training program, you might want to look at it through this lens. The previous slide was more about what a health system needs to have in terms of capacities. This slide is more about what an individual scientist needs to develop in terms of competencies. Competencies in system science, research methods, informatics, ethics, leadership, and engagement. Many of these things we might develop in a traditional research model, but not necessarily. because here we're inherently interacting with the health system. We're inherently sort of pushing on the edge of what we might consider traditional scientific research. We're inherently involving informatics and implementation science. So a learning health system scientist needs to have familiarity with all of these competencies and probably others. All right, that was part one. Let's move on to the next part. Okay, so if we are going to do research in a learning health system model, what might that look like? If you're a scientist in training or one in practice, you might wonder, well, where do my skills fit into the learning health system methodologies? Well, fortunately, there are a lot of methods that can be used in learning health systems. This vast spectrum, moving from observational research on the left, all the way to implementation science on the right, with improvement science and clinical trials in the middle there. All of this can be deployed in support of a learning health system. And that's one of the things I enjoy most about my job is I get to work with interdisciplinary teams who have expertise in different areas along this spectrum. And together we're able to devise research projects that maximize learning through the use of many different methods. On the next several slides, I'm going to share some more details about the last four of these columns, from quality improvement all the way to implementation science, and give you some examples from our own health system of research that's fallen into these categories. So let's start with improvement science. This is the Institute for Healthcare Improvement Model for Improvement, the IHI model, as it's called. And the notion here is that we do cyclical improvement work. By itself, you may not think of this as a scientific approach that would be part of a learning health system model, but that cyclical aspect really has its roots in quality improvement. Within a given project, we often tend to design an intervention at the beginning and set it and forget it and collect our results 2 years later in a traditional model. But learning health system science tells us that if we see an opportunity to improve that intervention, we should. And we should study it in a way that it's still rigorous. And so the plan, do, study, act cycle has an important role. As we iterate on our interventions, they often increase in complexity over time. We may find at the beginning, for example, that our intervention reaches the 70% of our patients that are easiest to reach. And a subsequent iteration might spend a little bit more energy on populations that are harder to reach in the name of improving health equity, especially for those populations. We might develop more innovative strategies or require more in-depth strategies to improve our project over time. And this improvement cycle can provide a very useful model for thinking about deployment of interventions in a learning health system. So I'm going to give you one example of that. From our surgical environment, many of you, if you're in clinical practice, especially in surgery, may be familiar with the Enhanced Recovery After Surgery, ERAS model. I won't go into this in detail, but the general concept is that when a patient has an upcoming surgery, we can be attentive to the full patient in terms of their functional status, their nutrition, how quickly we get them off sedatives and off a ventilator, all in the spirit of promoting a faster recovery. And our surgical lines implemented the ERAS model across multiple different departments and developed a leadership group that brought everyone together, created methods of following our progress across each of these lines, and in a continuous quality improvement model with iterative improvement, kept pushing at it to work on enhancing the fidelity of our implementation of this model. And over time, this graph shows a period of 5 years through continuous improvement under the supervision of a leadership group, brought the rate of ERAS compliance really quite high, up above 80% and consistently. In at least one surgical line, this was associated with a decrease in postoperative outcomes, complications, and a decreased length of stay. Shifting gears to another type of research method that you might see in a learning health system, let's talk about a quality improvement, a quasi-experimental study. So this is an example from early in the days of the COVID pandemic. It had been thought that extrapolating from other evidence in the ICU setting, that when patients were hospitalized with COVID and their oxygen levels were low, they should improve faster if they were told to lay on their stomach. In the ICU environment, for somebody who's on a ventilator, that strategy is proven effective for increasing oxygenation for the areas of the lung that are hardest to deliver oxygen to. And one of the practices that hospitals were picking up, again, extrapolating from this evidence, was even when somebody was hospitalized and wasn't on a ventilator, they were telling patients to lay on their stomach. So there was no evidence to really guide this. And this is one of those scenarios where in clinical practice, we said, should we be doing this outside of the ICU? And so we developed and quickly carried out a quasi-experimental trial, which tested whether or not encouraging patients to lay on their stomach versus not, and their usual default position would be on their back, whether one was better than the other. We engaged all the clinicians caring for these patients. We developed patient education tools. And based on the patient's medical record number, even or odd, they were assigned to either the supine group or the prone group. And then we followed them. We were able to quickly amass several hundred patients in this study and evaluated a range of outcomes, some of which were more clinical and some of which were more patient-centered. And we basically found there was no difference in these two practices. And this was the first experimental study published in this space. This flew against what was being recommended in practice at that time, but subsequent studies verified this, and a meta-analysis subsequently verified this. And this practice essentially stopped as a result of this study and others. Now, had we been traditional researchers, we might have taken 2 or 3 years to carry out this study, selected a very specific patient population, but here we wanted to get answers quick. We set it up in a way that almost every patient would qualify for the study. We made our outcomes very easy to collect so that we could do it quickly and analyze the data quickly. And we were poised to adjust our hospital practice immediately when the results of this study were completed. So in this case, our time from research question to practice change was well under a year. And that's because we conducted this with a learning health system mindset. The next type of method I want to talk about that you might see in a learning health system context is a pragmatic clinical trial. This type of randomized controlled trial is becoming more and more popular. And let's begin just by contrasting it against a traditional or explanatory clinical trial. So on the left is a characteristic of a typical clinical trial, and on the right, a pragmatic trial. So what about the research question and the setting in which it's carried out? Under a typical trial, the research question is often very narrow. That can be the case in a pragmatic trial as well. But the key conditions are that a pragmatic trial is conducted in the messy real-world environment. The population in a pragmatic trial is intentionally broad and heterogeneous. As I mentioned in the previous example of a quasi-experimental study, we want to include as many patients as possible. That helps us get the answers more quickly and makes it more generalizable. The healthcare providers involved in a traditional trial often are extensively spending their time to verify patients' eligibility criteria, do intake assessments, do follow-ups. Those may be physicians or nurses or other healthcare providers. In a pragmatic trial, it's very light touch. There should be little to no incremental time spent on the part of the healthcare professionals, taking care of the patients or leading the research. Some other differences are that in a typical clinical trial, the intervention is highly standardized. It's set at the beginning of the study, and that exact intervention is carried out for what may be multiple years. In a pragmatic trial, we commonly have a process where we have a run-in period, make some corrections about things that aren't quite going right. We might flex the intervention a little bit, and then we follow how that's going for the main trial results. The cost, as you might imagine, because it's a lighter touch, is a lot cheaper in a pragmatic trial. Many of these can be done with no funding at all. And even large trials that are conducted in a pragmatic approach cost just a fraction, 10 to 20% of what a full effectiveness trial would typically cost if done in a traditional way. At the duration of a pragmatic trial, we often want to get results quickly so we can use them. We're enrolling a lot of patients, so the time period tends to be quite limited. Ours are usually about a year or less. And the goal is to immediately be ready to implement those findings. Because remember, it's not enough to just get the answer and publish it. You need to bring that information back into your health system and act on the data. Whereas in a traditional trial, that's not typically what happens. Now, you can randomize at different levels. I'm not going to go into a lot of detail on this, but there are circumstances where you might want to randomize at the patient level, which is what this slide illustrates. This would be done ideally when you can cleanly deliver the intervention to patient A, but not patient B. There may be situations where it's not so easy to do that. For example, if patients are followed by the same healthcare professional or in the same clinic, there might be too much mixing of practice. So if you're changing the way a clinic operates or the way a team operates, you just can't randomize at the patient level. So we might randomize at using a cluster design, where you cluster at the level of the team or the clinic or the nursing unit, for example. There might be other scenarios where you need to train groups as the intervention is rolling out, and you can't do that all at once. I'll share an example of this in a minute, but a stepped wedge randomized trial breaks your ultimate group of sites into increments. Those might be nursing units, they might be groups of physicians, they might be clinics, and randomizes the order in which each site goes live. And before they go live, they receive the training and the tools are turned on and all the startup activities occur for that group. So if that's a pretty intensive process, it also spreads out the efforts of the research team to be able to do that sequentially. And a randomized trial following a step wedge design allows you to do that. It also makes sure everybody ultimately gets the intervention, which might be important in terms of getting buy-in, especially if you're making a system change and you just can't do it all at once, but you want to get rigorous data about the effectiveness of that, because each unit of randomization serves as its own control based on the historical behaviors and outcomes in that unit. So it's very powerful statistically. There are other more complex designs, which I won't go into, but we're seeing this now in implementation science in particular. We might see adaptive randomized trials in which we're trying to affect a certain behavior, and there may be multiple ways to do it. Some are easy, some are hard. We might randomize patients to first get the easy intervention and see how much mileage we get from that. And then among the non-responders, do a second randomization using something that takes more effort and see how much mileage we get from that. The goal would be to learn how much you can move the ball down the field with different levels of effort with this type of study design. So let me give you an example of a couple of these. This is another study published from work at Vanderbilt in which a question comes up a lot. Which antibiotic should I use when somebody's hospitalized with an acute infection? And in our clinical practice, about half of the time we use a third generation cephalosporin, and about half the time we use an anti-pseudomonal penicillin. And so those were the two things tested head to head in this randomized controlled trial. It was done in a pragmatic way, such that when a physician went to enter the order for either of these in the electronic health record, a little pop-up came up and said, hey, your patient qualifies for this study. Would you agree to randomize them to one or the other treatment? All I had to do is click a button, and that was it. No time cost for the physicians taking care of the patients. The data were harvested through the electronic health record afterwards. very easy to follow outcomes. We looked at kidney disease progression, which was one of the differences that was thought to exist between these two antibiotic regimens. We looked at mortality after this infection, and we also looked at neurologic complications, which did take a little bit more effort to assess and was thought to be one of the other differences between these two regimens. And we basically found out there's no real difference between the two. And we were able to do this 5,000 patient study. Sorry, I'm not looking at my numbers properly. 2,600 patient study in about a year. And it was very generalizable because it enrolled a whole number of patients across infectious conditions. Because patients were being randomized to two different treatments, either of which was very acceptable in clinical practice, IRB determined that this bore no more than minimal risk. It was consistent with the spectrum of care they might get anyway, depending on which physician's preference there was. And we did not need to do individual patient level informed consent. And that's another key feature of a lot of pragmatic clinical trials, especially those in a learning health system model where we might be testing two equally viable approaches head to head. If you can set it up in a way that it doesn't require direct patient level informed consent and your IRB is amenable to that, you can do large studies very, very efficiently. So here's that example of a step wedge randomized controlled trial. There are a few dozen people on this call right now, and if data holds, probably 20% of you have been told at one point or another that you have a penicillin allergy. Well, most of you don't. And the usual scenario is, well, I had a rash one time, I took penicillin when I was a kid. That may or may not have been due to penicillin, and your body might have forgotten about that. And so what this trial sought to do was delabel patients who are thought to have penicillin allergy by doing a risk assessment through some questions and then giving them one test dose of an antibiotic from a penicillin family, amoxicillin. And this required a lot of work. We had to train the nurses, there had to be a pharmacist, we had to roll out the questionnaire. And so this was a trial that lent itself to a step wedge design, where we rolled it out across subsequent hospital units at our university hospital. And we found that when patients were exposed to this intervention, we were indeed more likely to be able to delabel their penicillin allergy through a combination of questionnaire for risk assessment and then a single test dose of antibiotic. I want to share another type of study with you, which is one I'm conducting right now. This falls in the spectrum of an implementation trial, which is the last method on that graph I showed earlier. In this study, we're addressing a problem of heart failure patients commonly being admitted to the hospital. So typically, about 80 to 90% of the time, when somebody has known heart failure and they come in fluid overloaded, they get admitted to the hospital. Yet, not everybody necessarily needs to be admitted. And so what we did in this study is we took a prediction model that had been previously validated to identify low-risk patients, and we developed a set of implementation strategies using clinical decision support as the anchor to bring that into practice and try to change practice. So across 10 emergency departments in the United States, we developed and deployed this electronic health record-based risk stratification tool, which is called Stratify. And this shows you a screenshot where the score is automatically computed in the first hours that a patient is in the emergency department. They're stratified as low, medium, or high risk. That information is served up to the clinician through the electronic health record. And it's pointed out that maybe you should consider discharging this patient if they fall into that low risk group. Now, it's not enough to just throw something into the EHR and expect people to use it. So we developed a very detailed set of implementation strategies around this. In the phase before the intervention launched, which I'll call pre-implementation, we engaged all the relevant clinicians and other groups. We met with patients about their preferences for being involved in decision-making. We developed and tested educational materials, both for the clinicians and the patients. During the implementation phase, we developed tools to monitor how frequently this tool was being used in practice. We developed ways to bring the data back to the clinicians through providing feedback about how often they were using it. And this is another example where we intentionally put in a step of reevaluating the intervention delivery early in the study. It would have been a mistake to just roll this out with what strategies we thought were going to work. As much effort as we put into that, we can't anticipate all the real world variables. So we intentionally built in a pause in our study design a couple months after the intervention started to look at what was the uptake, where were people having challenges, where did they find it was most useful. We recalibrated the way we were doing things, changed a few things about the EHR interface and some other details, and then continued forward. Doing this allows us to learn early and then evaluate the effectiveness with enough time period to follow up. Just to give you some other examples from this study about the methods we're using, this is a Gantt chart which laid out week to week which strategies we were going to deploy in the pre-implementation phase. And then for each implementation strategy, we detailed who's carrying it out, with whom, what's the exact action, how long are you going to spend on it, when is it going to be done, what outcomes does it tie to? And we did this for each and every implementation strategy so that somebody else who wanted to understand what we did in this study would be able to look at that and replicate it. We're also monitoring this across sites. I mentioned it's in 10 emergency departments. And this provided us a roadmap to see, what differences might there be in the way each site was implementing this. Were they doing comparable trainings? Were they, getting the same type of feedback performance to the clinicians? So it helps us understand our own results when we get them. I'm going to shift now to the third part, which is more of our journey as an institution toward developing as a learning health system. This has been a long journey for us. And I know from talking with a couple of you all before today that you're taking a very intentional approach to developing your own learning health system. I hope you do it faster than us. I think you will. I do want to acknowledge that the roots of this really started in the year 2000 when our Center for Health Services Research was founded. And we also started one important training program, which is the Veterans Affairs Quality Scholars Program. That was when that launched. Fast forward 14 years. The institution said, hey, we really need to have an academic home for implementation science. And we founded the Center for Clinical Quality and Implementation Research. We then developed a core service so people could utilize that. Then we had several other steps that started happening more rapidly. Our Clinical and Translational Science Award, the CTSA, decided in the 2017 submission to put a particular focus around learning healthcare, as we call it there, by allocating funds to the development of a clinical trials infrastructure for pragmatic trials. That's also when we got our first Career Development Award grant, a K-12 program, which allowed faculty from Vanderbilt to compete internally for fully funded career development spots focused on implementation science. Since then, we've developed coursework in our MPH program, developed 2 postdoctoral training programs funded by T32s, 2 more faculty development programs funded by another K-12 and a P30. I started an annual symposium on learning health systems 6 years ago. Our institution decided to invest further in this space a couple of years ago. And we also developed some funding from PCORI, the Patient-Centered Outcomes Research Institute, to further our implementation efforts. And this last year, we've even taken a step into genomics with a new program from NIH called a Genomics-Enabled Learning Health System. So there's been a lot of activity in this space, and this doesn't even encompass all of it, but these are the main ones. And one thing that I've learned through this is you can successively build these blocks on top of other ones to really continue to grow and develop additional capabilities. So I'm going to tell you more about a few of these. Let's start with the Center for Health Services Research. which, as Selmy mentioned at the beginning, I currently have the honor of directing for just the last 5 years. So our Center for Health Services Research is our home academically for a whole array of methods, ranging from, you know, patient behavior and health education research, all the way through to economic modeling. We have more than 200 faculty that are affiliated with the center, and it's a very robust group academically. We operate 3 core services so that other investigators can easily tap the expertise. But the primary functions we provide are giving an academic home and fostering collaboration among the scientists, because just about everybody who's affiliated with the center is primarily a researcher, either PhD or a physician who spends the bulk of his or her time doing research. Our centers at Vanderbilt function across departments, so this doesn't belong to one specific department. In fact, we engage the School of Medicine, School of Nursing, School of Engineering, and the School of Business, as well as 14 individual academic departments within the medical school. We also house about 20 smaller centers and programs within health services research. So one of them is the Center for Clinical Quality and Implementation Research, which, as I just mentioned, was founded about 10 or 11 years ago. So this is our academic home for improvement and implementation sciences. We've got about 40 faculty affiliated with this. And this is where we provide some shared infrastructure for these training grants. So at the faculty level, we've had 3 training grants. 2 of them, the K-12s, are now done, but we're on the P30 right now. And then we've been able to support 3 postdoctoral research programs, which operate in parallel and bring those scholars together. One of the other resources that I mentioned earlier, which I'd like to tell you a little bit more about, is this platform for pragmatic clinical trials. Again, this was initially funded through our CTSA award. It has subsequently been sort of spun off a little bit as a center for learning healthcare. The focus of this center is creating an infrastructure to efficiently carry out pragmatic clinical trials. And there are mechanisms which have been set up so that when an investigator has an idea, they go through an intake process and a small team helps them develop that methodologically. We workshop it and flesh it out some more, present it to an executive review committee that helps approve it, and then it's refined further and then carried out with whatever IT support and project management and statistical support might be needed. Most of these trials are done within a 12-month period, and the vast majority are set up in a way that we're testing 2 generally acceptable approaches to care, and this does not require patient-level informed consent in order to do this randomization when the trial is set up that way. Another activity which has been very important in our institutional journey as a learning health system is our annual symposium. This takes a big tent approach, specifically trying to bring together the academic researchers in this space, the trainees, and a lot of health system leaders. It's a day-long program which includes a poster session. We bring in a keynote speaker from outside, and we usually have 2 interactive panels taking a deep dive into specific issues that are contemporary to that year. So in last year's symposium, for example, we talked about doing pragmatic clinical trials, but through multi-center studies. And then we also talked about challenges in AI and implementing those models into practice. We recognize one operational partner each year, and this is just in recognition that we can't do this work as researchers without effective partnership from our clinical and operational leadership. I mentioned we've been fortunate to get some funding from PCORI. PCORI recognizes that a lot of research doesn't get translated quickly enough into practice. So they set up a new initiative called the Health Systems Implementation Initiative, which funds about 40 sites around the country to be part of a learning community. We also got capacity building funds which we used to develop a short course in improvement methods training for managers that oversee a clinical area. We developed some toolkits around evidence-based implementation strategies. And then we also brought together our data analysts who work for the clinical and operational enterprise, not the research analysts, so that they could start learning from each other and utilize best practices in a lot of the reporting they do to evaluate health system initiatives. As part of this overall initiative, we're now applying for and competing for annually implementation projects in a specific area. So one that we're just starting now is around antibiotic prescribing for children with respiratory tract infections. And hopefully we're going to be starting another one soon on hypertension management in primary care settings. Just as an example of the collaboration, I co-lead this with a very good colleague whose name is Jenny Slayton. She's our Senior Vice President for Quality, Safety, and Risk Prevention, essentially our Chief Quality Officer. And so she's able to help bring to the table more operational leadership and engagement, and I bring the academic part to the table, and it's been a wonderful collaboration. So we were doing a lot, and we said, you know what, let's pause and see how we're doing and what we should do next. And so very intentionally, in 2023, we did a needs assessment and strategic planning to guide the next steps in our journey as a learning health system. We did one-on-one interviews with leaders from across our clinical and academic enterprise. We asked them to reflect back on what we have right now or then as a health system. What were the key gaps and opportunities? What services do they think we should focus on developing? And do they have any specific projects in mind that would benefit from a learning health system approach? And then we followed these individual interviews with a half-day strategic planning workshop where we brought about 30 people together to really reflect and spend time together and also help prioritize what we would be doing over the next few years. This was very successful. It was an opportunity to reflect and recalibrate where we should spend our efforts. And the needs assessment basically pointed us in a couple of directions. The primary one was around, although we had a place for investigators to bring research ideas for pragmatic trials, we didn't really have as good a place for health system leaders to bring projects that they wanted consultation on. And not all of them fit a pragmatic randomized controlled trial design. So in some cases, they might have already implemented something and they want help evaluating it. And we need to be able to conduct retrospective analyses. In other cases, they've done it in a small setting and are thinking about spreading it. They need implementation science. How should that be adapted to different areas that have different clinical contexts? They wanted help applying rigorous evaluation, but in a real world setting, without getting too caught up in being perfect, and instead focusing on something that would be rigorous, would answer questions, and which we could do quickly, again, in a period of like 3 to 12 months for a lot of these collaborations. We also needed a way to prioritize projects. One of the things that most medical centers have is a decision-making process for one initiative at a time. They might annually get together and set priorities as a medical center. But when we're talking about where to spend limited academic bandwidth, especially if we're in an environment where we like to say yes to things, we have to have a mechanism to prioritize how much time we're going to spend on different potential collaborations. So we've been developing all that. And this also enabled us to do a SWOT analysis, which I won't go through in detail for the sake of time, but I'll just highlight some key opportunities here. It's an opportunity to bring patient outcomes more broadly into health system initiatives and to inform that resource allocation and do it in a way that is efficient and effective and hopefully advance general approaches to this, which other medical centers might be able to benefit from as well. So we call this the Rapid Learning Health System, and this actually coincided with the funding of a new center grant, which is called Rapid LHS. So we've been leaning into that brand. There are several aspects of this. One is to train a group of scientists at the faculty level. So we have slots to fund 5 scientists to do embedded health system research projects. We've created core services, and we've also created mechanisms to provide collaboration and consultation to health system initiatives primarily. So to tell you a little bit about the consult service, this is essentially a place where someone can bring an idea and through an intake form request a group get together. We construct that group in a way that's tailored to the questions that are being brought forward. So we have about 7 or 8 people who are regular attendees or invited regularly, and then some others that we call on. We do a 1-hour session with them and provide a consult. And they can follow up at another stage of the work and request another consult as the health system initiative evolves. Features that we wanted to lean into here were that it would focus on health system priorities. Although we do have some academic researchers request one of these consults as well, but the work is not just research in a vacuum. It's evaluation of a health system initiative or research within an embedded health system setting. On the right side here are all the disciplines that we have access to engage on either a regular, as in blue, or as needed, as in clear, depending on the workshop topic. We have a project manager, and we're using AI for summarizing these notes and next steps, which is pretty neat. Some projects are important enough that they reach the level of ongoing collaboration. So Jenny Slayton, who I mentioned before, who heads up our quality, she and I sort of periodically, quarterly, survey stuff going on and identify things that we think are potential for a more in-depth collaboration between an academic team and the health system. We bring it to a review panel of people that we've comprised who have sightlines across the whole health system. They are people like the chief of staff or the chair of the Department of Biomedical Informatics, and there's about 5 or 6 people. They help us prioritize which initiatives are going to be most impactful for patient care or the health system. We then reach out to those initiatives and do a workshop and then develop a plan of deliverables with a project team and a timeline to move that academic collaboration forward. And we provide that ongoing support to leverage whatever resources they already have and bring some additional services to the table. We also help them publish that work and hopefully for some of these apply for a future grant. We use the acronym RAPID to focus in on projects for our prioritization scheme that are relevant to the health system, aligned with academic interests. We have to have somebody who can carry this work forward. Already has a team in the health system that's funding and supporting and organizing the health system project. Academically, we're not taking that over. We're bringing in additional collaboration. It needs to be impactful, and we need to be able to do it in a reasonable duration. So to date, we've offered this for about 12 months now. We've supported 18 projects, which was on par with our estimates that we put forth initially. Some of these are just one-time consultations, and that's fine. We need to have that mechanism. And then 11 are ongoing collaborations, some of which involve those funded scientists who are supported through this grant that I mentioned. All of this has helped us build a broad ecosystem. And this is my last slide, which encompasses a lot of different areas. There's no one learning health system at Vanderbilt. It's an ecosystem of groups that already existed or ones which we've built that includes expertise in quality, effectiveness research, implementation science, practice implementation, training, health equity, engaging leaders and patients, and clinical informatics. And within each of those areas are different offices, departments, grants, and such centers that have expertise and are engaged in those areas. We try to bring them together in some way across projects. But I think there's been a big cultural shift in the last few years, especially, which was part of the reason why we did the strategic planning session, bringing in so many people to participate in the development of this next step in our vision and then they are key people and supporters in helping us carry that out. So with that, I'm going to stop, and I'd be happy to take any questions that you all might have.
This was great. Thank you so much, Dr. Kripalani. I think I like how you tied it together at the end and showed us how it's become this broad ecosystem, as you said, number of centers and lots of people engaged. So thank you. Yes, we'd love to open it up to questions. We have some time for that. And maybe as people are thinking, oh, there we go. O'Neill, let's go ahead.
Hi, Dr. Kripalani, that was very remarkable. It's amazing the breadth of work you guys are doing. I'm curious, if you think of academics and operations people as having distinct interests, how do you bring those things together? And is it the fact that the academic is paid? Like, what makes it easier for these groups that have different interests to come together?
Absolutely. That's a very important area. And it really comes down to money, right? Academic researchers like myself have been incentivized to get external grants and publish papers. Operational leaders are incentivized to get the work done efficiently and do it well and meet institutional metrics. We really try to find the overlap of those two circles. So, for example, in the collaborations that we do, we want it to be valuable for the operational partner to receive this academic input. So we really anchor it in what their needs are. For example, often our health system data analysts have done, a longitudinal, unadjusted analysis of metrics. But the leaders interpreting that aren't really sure if it takes into account all the covariates or co-interventions that occurred. So we can bring that know-how academically. For the academic side, we're really planning on generating some scholarship out of each one. So there's value in publishing those papers, and the collaboration between the two groups shows that you can do that. We also don't expect our junior academic scientists to be spending a lot of their time on this, because they really need to focus on developing their research careers. So the people, for example, who are most heavily involved in doing the consultation and collaboration are at the associate professor or professor level, already tenured, can have a little bandwidth, take their foot off the gas a little bit, to give 5, 10, 20% of their time over to this initiative, depending on the person. So our institutional investment in this space helps fund some of that time.
Great. I have a quick question about kind of the team and who really helps to get the nuts and bolts, in operation and things like that. If you could describe a bit more about, I know there are a number of centers and you described a shared infrastructure, but in terms of, who are the key core people?
Yeah. So you have a small and mighty team. My
Mhm.
research lab manager provides mentorship to the staff who help with the day-to-day work. Right now, we have one staff person who's a master's level person who organizes and serves as a project manager for our meetings. We also have a statistician who's got 40% of his time allocated, really a critical member of the team. And then the other people are these implementation scientists or learning health system scientists that provide the academic guidance. I think as the portfolio grows, we'll need to add more people. For example, we're developing kind of a complementary portfolio around just the health information technology advancements. And within that, just the AI. And because there's so much moving so fast. So I don't know what that's going to look like just yet. But we'll need to continue to resource it appropriately. Right now, we figured that with this infrastructure, we can do about 5 to 10 collaborations a year and somewhere around 10 or 15 one-time consultations a year.
Opening it up to further questions.
Maybe I'll jump in. I put it
Yes.
in the chat.
Oh.
Thank you for an excellent presentation. Very clear, very systematic. I really enjoyed it. I really liked your whole concept of the learning health system as an ecosystem. And I'm wondering, voices that often get neglected are the patient and the community voice in these ecosystems, even though they're the main element of what we're doing. And I'm wondering, how does that voice and how does that commitment play in your system?
Yeah, phenomenal question. From the beginning, for our pragmatic trials platform work, we've had a patient representative on the steering committee. We also utilize our community engagement panel, which is another part of our clinical and translational science award. So the work is presented to them regularly. That voice has been especially important around this issue of informed consent. That's an issue, a question that comes up a lot as we talk about this work. And we have needed and valued the patients as a sounding board. Like, does this sound okay? Like, under what circumstances would you feel you're being experimented upon? Things like that. And their voice has been critical. I recognize that we still have a lot of work to do. So, in fact, for our 2025 Learning Health Systems Symposium, we have an entire panel called something like patient involvement in the learning health system, where we're going to really bring out those key points where patient input is so critical and examples of how to do that well.
Joyce, I think we have time for one more question.
May I ask one more if no one else?
Sure. I don't see any hands. Please go ahead, Joyce.
So Sunil, a big part of what I'm doing in building capacity within the learning health system is bringing in trainees in health professions into the program. And do you have explicit, I saw with your symposium that you're bringing trainees in. Can you elucidate a little bit more on how trainees are supported and also encouraged to participate?
The training grants have really been key there. And we've got a community of about 30 trainees who are funded through the VA Quality Scholars, through the 2 T32s, which all have a specific attention to implementation science, improvement science, health services research, learning health systems, and then another 5 through the rapid learning health system. But we allow anybody else who's in any other training program to participate in these offerings. So we have people, for example, in the Department of Pediatrics T32 postdoc, whose research interests align with the work we're coordinating in the Center for Health Services Research. So they join in on those educational activities. So for the trainees, they write it into their individual development plan. They follow their progress through their annual reports in terms of their competencies in these learning health system areas. ARC has a wonderful set of competencies, further detail behind that blue circle I showed, with great detail, and it provides a roadmap for our trainees about some of the skills they should be developing. So we have them self-assess their skill level at the beginning of the program, and then annually, and discuss it with their mentorship committees so they can intentionally build skills where they feel like they need to as part of their development as scholars.
Great. Excellent work. Thank you again, Dr. Kripalani. We really appreciate your time and expertise and really walking us through numerous examples of trials and really showing us a different facet to all of this. We'll meet you again, I think, shortly in the post-seminar chat, and want to thank the audience as well for joining us today. Feel free to reach out to me if you have any questions, and yeah, we'll see you again next month. Thank you again.
Thanks so much.